Well, I just want to thank the Academy for inviting me to speak today. I was asked to talk about how the Agency for Healthcare Research and Quality minimizes bias in the systematic reviews that come out of the agency. So that's what I'm going to spend my time talking about today. Just by way of introduction, I'm a general internist and a clinical epidemiologist. I direct the Evidence-Based Practice Center division at AHRQ, and I'm a senior science advisor in our Center for Evidence and Practice Improvement. I'm going to show my disclosures and disclaimers slide and spend a bit more than 2 seconds on it. I have no financial conflicts to disclose. I am an adjunct professor of medicine at Georgetown and provide clinical care at MedStar Georgetown University Hospital. So the first part of my talk is just going to be a very brief introduction to ARC and the Evidence-Based Practice Center program here at ARC. And then I'll spend most of the talk talking about our processes and the steps we use to mitigate bias and enhance rigor of our systematic reviews of the scientific literature. So as many of you know, the Agency for Healthcare Research and Quality is one of 11 agencies in the Department of Health and Human Services. This is the mission of ARC, to produce evidence to make healthcare safer, higher quality, more accessible, equitable, and affordable, and to work within our Department of Health and Human Services, as well as with other partners, to make sure that the evidence is understood and used. So research evidence is an important part of our day-to-day operations and goals here at ARC. The ARC Evidence-Based Practice Center program is a program within ARC that was established in 1997. So it's 25 years old this year. And we've actually taken some time over this past year to celebrate and recognize the contributions of many throughout the life of the program. We have a website dedicated to the 25th anniversary that you could find on our webpage. But the EPC program has provided systematic reviews of published scientific evidence on a range of health topics for a range of requesters. And over the years, many of those topics have been clinical topics, such as comparing one treatment to another. But more recently, some of those topics have been examining different approaches to healthcare delivery. For example, doing reports looking at different approaches to reducing hospital length of stay, or estimating the error of misdiagnosis in the emergency department. Our program also invests heavily in methods development for evidence reviews. And to do this work, we contract with 9 academic research organizations. I just want to take a moment to share who those organizations are, because a big part of how we ensure rigor and minimize bias in our work is to work with individuals and groups who have deep experience and expertise in this space and have systems in place to ensure disclosures of conflicts and to minimize conflicts of interest. So these are the 9 evidence-based practice centers that we work with currently, 4 on the East Coast, 2 in the Midwest, and 3 on the West Coast. I also wanted to highlight the staff that we have within our division, because these are individuals who, again, have deep expertise and experience, both in the clinical topics that we review, but also in systematic review methods and the methods we use throughout our process to ensure transparency and minimize conflicts. So we have surgeons, pediatricians, general internists, pharmacists, nursing leaders, obstetricians, and many others who make up the skill set of our talented division. The impact that our program has is really based on the trust that users have in our products and the partners who we work with. This is a slide depicting some of the most common partners who we work with. So we commonly work with guideline developers, both within the federal government, but also outside the federal government, such as professional societies. And here are just a few examples of guideline developers that we've worked with over the years: USPSTF, CDC, American College of Physicians, and they use our evidence reviews to inform their clinical practice recommendations. We work closely with healthcare policymakers, both within and outside the federal government, such as CMS and Congress, and they use our evidence reports to inform policymaking. For CMS, that's national coverage determinations. We work closely with research funders, such as NIH and PCORI, who use our evidence reports to help inform and prioritize their research agendas and their funding opportunities. So over our 25 years, the program has completed over 800 evidence reviews. We've worked with over 100 unique partners, a third of them federal, 2/3 of them in the private sector. Almost all of these partners have been repeat customers over the years. And this work has informed approximately 200 U.S. Preventive Service Task Force guidelines, over 200 clinical practice guidelines by federal and society partners, 35 national coverage determinations by Medicare and Medicaid, and 40 NIH research prioritization meetings. So that's just a little about the ARC Evidence-Based Practice Center program. So what is an ARC Evidence-Based Practice Center systematic review? Well, like most reviews, it's a summary of the overall evidence to address a set of key questions that are identified. It's protocol-driven. It includes a comprehensive search of existing peer-reviewed studies. We critically appraise each study identified, and then we summarize findings for each key question across important outcomes, including benefits and harms. And our methods are based on the National Academy of Medicine standards for systematic reviews, which ARC helped fund. I don't have time to go into all of the details of our process, so I want to just take a 30 or 50,000 foot view of our process. These are some of the big steps that I'm going to talk about here. We do a lot of work in preparing and refining the topics which our systematic reviews address, and that work helps support transparency, improve rigor, and minimize bias. I'm going to talk a lot about how we select studies for inclusion and how we analyze and synthesize those studies and ultimately report those findings. And I'm going to use as an example for this talk a report that we just published with partnership of the American Epilepsy Society and PCORI, looking at management of infantile epilepsies. And this is a report that was published in late October, and it includes evaluations of different types of interventions to manage infantile epilepsies. So I thought it might be a nice example. So most of the reports that we work on are essentially identified through two different means. One approach is a federal agency asks us to do a systematic review to inform a federal policy or a federal decision, and they pay us to do those reviews. The other group of reviews that we do are reviews that are nominated by the public, and we have a budget to do a certain number of those reviews annually. But we get so many requests that we have to prioritize what topics we're going to address. And we've put together a process that we hope is as transparent as possible to minimize bias, even in the process of selecting topics that we're going to address. So the topics have to be appropriate for review. They have to be related to healthcare, interventions that are available in the U.S. It has to be an important topic, significant disease burden, vulnerable population, high interest or costs. There can't be a recent systematic review on the topic, otherwise we'd just be duplicating that work. But there have to be existing studies that we can synthesize. And importantly, there has to be an end user identified partner who's going to work with us to help shape the review, but also disseminate and implement the review for change. And the review that we did on management of infantile epilepsies met all of those bars, so it was prioritized for review. So after making a selection of a topic that we're going to review, we do a lot of work in scoping the key questions for the review. And again, this work is focused on increasing the rigor, transparency, and minimizing bias in the process. So we flesh out who is the population that we should be examining. What are the specific interventions and comparators that we should be examining? What are the outcomes that should be included in our evaluation? Are they clinical versus surrogate outcomes? Are they patient-centered outcomes? And we rely on experts to inform the scope of the review. And so for our review on management of infantile epilepsies, we worked with pediatric neurologists, neurosurgeons, epilepsy nurse practitioners, dietitians, doctorates in epilepsy research, and an executive director of Family and Advocacy Foundation to help us scope and inform the protocol for the review. And I just wanted to note that the experts that we include must disclose financial conflicts of interest and any other relevant professional COI. We have particular forms and processes for that. But because of their unique content expertise, those with potential conflicts may still be retained to help scope the protocol. And we aim to balance, manage, and mitigate potential conflicts of interest across the expert panel that's going to inform the protocol for review. Now, for the infantile epilepsy review, I'm showing here the analytic framework, which helps you understand the population, intervention, comparator, and outcomes that our review was assessing. So we're assessing infants less than 3 years of age with epilepsy. We're assessing a host of interventions, pharmacologic, dietary, surgery, and others. And we are looking at both intermediate and patient-centered health outcomes, as well as adverse effects of these interventions. And just to give you an example of how detailed and transparent we are, we look to the experts and the literature to help us understand what are the different specific types of interventions that we should be including in our reviews. And that will include, this is an example here of some of the pharmacologic interventions that were included. What is the exact drug? What are the dosing regimens and modes of delivery that we should be evaluating? Now, the next step, once we put together our protocol, is doing a comprehensive search of their peer-reviewed literature. And this is a study flow diagram where you could see we've identified 11,000 records and ultimately include 41 studies in our review. And you could see the breakdown of pharmacologic versus dietary versus surgical treatments. So for these comprehensive searches, we put together search terms based on the protocol that we've devised, and they're comprehensive search strategies. We run these searches across multiple databases. And we use 2 individuals to independently screen those studies against agreed upon eligibility criteria. And then we use 2 individuals to extract agreed upon data from those studies and do that in an independent way and then compare the data that they've extracted. Once we identify studies that will be included in review, we do assess study risk of bias for each of those studies. And to do that, we use standardized risk of bias assessment tools that are often based on the type of study design that we're assessing. So for this particular review, for randomized controlled trials, we use the Cochrane Risk of Bias 2 tool. And for non-randomized studies with control groups, we use the Risk of Bias and Non-Randomized Studies of Interventions, or Robbins I tool. And I won't go into the details of all the domains assessed by each of these tools, but in general, the domains that these tools are assessing include how similar are the test and control groups evaluated in the studies at baseline. The hope is that they're as similar as possible, except for the intervention under examination. What is the adherence of the groups to their assigned intervention? Our hope is that they're as adherent as possible, and adherence is similar across the groups. What is the completeness of outcome assessment in each study group? Our hope is that outcomes are assessed in a complete way across all the different study groups, and study subjects remain in the study for the life of the study. And what is blinding of those who are prescribing and receiving the interventions and those evaluating the outcomes? Our hope is that all of these groups are blinded. That's the ideal scenario, but not always possible. So how can our risk of bias assessments help identify and mitigate bias resulting from conflicts of interest? Well, as we've heard in many of the talks in this session, studies might be selecting specific study designs or making particular hypotheses in order to favor the test treatment over the control. So our risk of bias assessments can help us understand, for example, if a study is selecting inferior comparisons of drugs and doses in their evaluation. And that would be flagged as such. Our risk of bias assessments can also help us understand if studies are selectively reporting outcomes. For example, are they reporting select outcomes even though there are multiple available endpoints? Or are they using composite endpoints without presenting data on individual endpoints? Dr. Redberg spoke a bit about this earlier. And this is an example of a risk of bias table for randomized controlled trials that was in our systematic review examining management of infantile epilepsies. So what you can see here is that each row of this table represents an individual study, and the columns represent the domains in the Cochrane risk of bias tool. So we have domains assessing randomization, imbalances at baseline, blinding, adherence to treatments, whether there's dropout across groups, whether there are standard ways that outcomes are being measured. And for each of these different domains in the tool, we're making an assessment of whether there are some concerns, low concerns, high concerns. And this helps us make an overall risk of bias assessment for that individual study. Then how do we use risk of bias assessments in our overall systematic review? Well, we can explore differences in results between higher and lower risk of bias studies. For example, if we have a set of studies addressing the effectiveness of a given intervention for a given set of outcomes, and some of those studies are higher risk of bias, some of them are lower risk of bias. If the findings are essentially the same across all those different studies, then that gives us more certainty of the findings that we're seeing. But on the flip side, if the findings are positive in the higher risk of bias studies, but neutral in the lower risk of bias studies, that gives us less certainty about the findings overall across the studies. We can also interpret impact of study risk of bias using sensitivity analysis. And this is something that we particularly do when we have outcomes that we can assess quantitatively. We can synthesize those outcomes using meta-analysis. So we synthesize those quantitative outcomes across studies. And we can look at the overall estimate of effect when synthesizing that information. And if the overall estimate of effect is about the same as the estimate of effect when we just look at studies that are low risk of bias, we can feel more certainty about the results that we're seeing. But if the overall estimate of effect is greatly affected by those studies that are high risk of bias, then that's concerning, and we have less certainty about the overall findings. And we can also use study risk of bias in our grading of the overall strength of the evidence for the different interventions that we're assessing. So to determine the strength of evidence, we grade strength of evidence for interventions across all studies in which they're evaluated. And we do this by outcome. And when we grade the strength of evidence, we consider factors such as what were the designs of the studies informing the outcome? Were all the studies randomized controlled trials? If so, we might think that we have a little more certainty in the strength of evidence. If all of the study designs were observational studies, we may have less certainty in the strength of the evidence. We can also look at the risk of bias of studies that are informing the outcome, the consistency of findings across studies, the precision of results. Are all of the findings across the studies highly precise, meaning that there were a lot of subjects in the studies and a lot of events? Or is there not much precision at all, and there's a lot of uncertainty around the findings? And then we also look at magnitude of effect of the outcomes across the studies. And this is an example of a strength of evidence table that's in our infantile epilepsies systematic review. And here you can see for the drug levetiracetam, for the outcome of seizure freedom, there's one randomized controlled trial and one pre-post study that has assessed this drug looking at this outcome. The risk of bias is high across these two studies, but these studies address the question at hand. The findings are consistent, that they increase seizure freedom in both of the studies, and the findings are relatively precise. So ultimately, there is low strength of evidence that adding levetiracetam may cause seizure freedom in some infants. After we finish a draft of our report, we release that report and post it on our public website and offer public comment. And we also have specific peer review. And then ultimately, when we post the final report, we also report a disposition of comments for all the comments that were received in this public comment process. And so you can see here that stakeholder engagement and transparency throughout this process helps us increase the rigor and minimize potential bias of our reports. And here were the ultimate main points that came out of this review. This is the executive summary. And you can see here this first main point: levetiracetam may cause seizure freedom in some patients, but data on other medications were insufficient to permit conclusions. And for many of our reports, we also have interactive visual dashboards on our site. And this is an interactive visual dashboard that's looking at percentage of infants who are free of seizures and months after initiating medications. And these different colors are the different medications that were examined in the report. And the size of these circles is the number of participants across the studies. And you can see in this visualization that levetiracetam has a high rate of seizure freedom after 12 months of starting the medicine. So all of our methods are informed by our methods guide, which is on our site. And we keep the chapters of our methods guide updated. And these are some of the relevant methods guide chapters to this talk here, guides both on grading strength of body of evidence, assessing risk of bias, and also when to include non-randomized studies of interventions and systematic reviews. And this is information about our website and to sign up for notifications. So I'm happy to take any questions if there are any at this time. Thanks.